actually analyze the patient accurately. When we do blood pressure tests or we check, like my car, I know how much pressure is in each tire in my car. What we're going to be able to do is to measure how much stiffness, how much mobility, what's happening in his spine. So what we always did traditionally is we kind of felt at people's spine to see how they bent and how they were moving, whether they went back and forth, side to side. And we were looking for areas that were stuck or irritated or swollen, but we couldn't really put a number on it. We didn't really know when we were done or what we'd done as far as treatment, how successful it was, because we could only go to how it felt. Now we can actually objectively measure the motion components of your spine. So what we're going to do is we're going to do an analysis of Dr. Paul here. We're going to put pressure on his spine at each level, and every time we do that, we are going to get a reading. Now, if we're measuring something firmer, something hard, obviously it's going to be totally stuck. If we're measuring my stomach, if we're measuring this desk or Paul's muscular shoulders, we're going to get a different reading. What we're going to be able to do is the system has been calibrated for the human spine.
Okay.
So what we want to know is we've established what the ideal motion characteristics are of a normal spine, how fluid or how flexible it's supposed to be, and we know what those numbers are. There's a patient education system on here for that tells them. So if we're looking at our graph and we get a nice, even, accurate graph with the right amount of stiffness, then we're fine. So if the curve goes up to an apex and comes down and it's nice and smooth, that's ideal spinal motion. If we find something that is too stiff or hypomobile in the spine, what we'll find is the curve won't be accurately rounded, it'll be left shifted. That's what we'll see. We'll bring it back to normal. If there's something that is too loose in the spine, it'll become right shifted, it'll go over to the right. If we find vertebrae that are very, very stiff, the amplitude will get higher, and we'll see that when we're going through Paul's spine. If we find somebody has swelling and we're poking at them and we go, is that stiff or is that swollen? If they have edema, what'll happen, instead of it coming down to the x-axis, it'll get very long. It'll run out to the side. If we have an older person who's got degeneration, they've got less water, less hydration in their system, they'll actually have shorter curves. So if you get an older person who has an injury or a fall, a lot of their curves will be shorter, and if they have an injury, they will have some that will actually show the edema, so you'll be able to know what's going on. And then when somebody's improving and their swelling's going down, their scans will return back into that normal range. There's another one that's not on here. If somebody has muscle spasm, instead of it being higher, it'll actually be very flat in a muscle spasm case. So we'll see how that works. So now we're able to actually know when we examine somebody or they're in pain, is it swelling, is it muscle spasm, is it stuck? And as we go through their spine and make corrections, we're going to be able to actually measure and see that we've actually created the changes that we wanted. And if we haven't, then do something else. Because not everything you do is always going to be exactly what you need to do at that time, so you can do other things. They may have to ice it. There might be other things we're going to do for that patient to get them well. So we have a starting point. We analyze them over on this side. So here's an analysis of what we talked about. So we have a pre-analysis, a composite screen, and each one of the vertebrae individually, so we can see what's going on. If we were to treat that person, if we were to select something, and this is not the way a normal person would look like that, but let's say we would select a particular level. Then we go to an adjust screen, we hit here. The algorithm in the computer then calculates what is the ideal speed or frequency of the adjustment to be the most comfortable and effective for that person. So in this particular case, if it was C3, it would pick 11.5 hertz, and that's the speed of the adjustment. What happens is we can choose different pressures to adjust. If it's a small person, we can use 10 pounds of pressure, which is very, very light. A larger person would probably use 20 pounds. Even a larger person in the lower back, we might use 25. Or some of our big rugby football players, we might use something like 30 pounds, which is a greater force. But what happens is the doctor makes the decision on the pressure to use based on the patient and what their needs are, but the frequency we never mess with. That's something that the computer is the brains of the computer. So if we were adjusting somebody at the right level with the right frequency, it's very, very comfortable because it's matched to the tissue. Now when we're doing an adjustment, this is the part the patients really like. When we're doing an adjustment, if I go back and I put it on Paul's spine, and I put it on the wrong level, it's going to recognize right away that there's no problem, and it's going to fire a couple times and stop right away. And if we're doing an adjustment, let's just pick a number, I put it on his spine, what's going to happen? It's going to fire until this number reaches 10. So what happens is if it hits it 10 consecutive times and it's not creating any change, it knows to stop. So it's not going to turn the patients into a hamburger. It's not going to over-treat them. It's not going to under-treat them. So what happens is, when we're doing our adjustment, it's going to be very accurate. The doctor's going to come back to the right level. He's going to apply the correct force for the right amount of impulses until the vertebrae are moving correctly, and then it's going to stop. Once it stops, in the old days, once we did our adjustment, that was the end. We didn't have anything else. Now what we want to do is we want to go back. It'll kick back over to this mode, and then we'd go back and we would reanalyze. We'll show you this in real time in a minute. But what happens is then we would reanalyze that patient down through that same segment. And what we'd like to see something similar to this. We'd like to see a lower amplitude, these frequency lines lined up, and an improvement. So if we saw an improvement in any of three things, if the lines were higher and they came down, we'd be happy. If they were left or right shifted and they came back to more balanced, we'd be happy. And if they're more even on a rainbow and they're coming down to a dot, that means that that's the kind of changes that we really want to see, because that's the changes that within the body, then the nervous system calms down, the joints move, the muscle spasm reduces, and healing takes place. So that's what we're trying to achieve. So when we achieve those changes, we can actually measure that the body's stiffness, flexibility, muscle spasm has actually improved. And that's what we want to do. So we do a pre-exam, an adjustment if necessary, a post-exam. If we're satisfied, then we would go to the next section of the spine. So we'll work through each section individually, work through the cervical spine, then we'd go down to the thoracic spine and through the lumbar spine, working on them sequentially. Once we're done doing our adjustments, if we want to do some soft tissue protocols, there's a whole system in here called protocols, and what happens is there's a lot of different things. So if we were going to go into the head region, what can happen? We can do headaches. There's a system for headaches. So if we're doing that, it actually goes through. It's preset to relax acupuncture points, pressure points, trigger points along the base of the skull, and it actually runs through a program where it actually takes a measurement of the stiffness of the individual at that spot. First of all, it takes a reading, measuring to know what frequency for that exact spot. It's not going to do the same thing all over, and then it would fire on that. We'll do this in real time in a few minutes. Next thing we can do, a lot of different protocols. We can do the cervical range of motion. If somebody has a problem with the range in their spine and they're having difficulty with rotation, it actually works along the muscles in the shoulder. Extension. People are always on their cell phones. They always got their chin down. They're always on their computer. We want to be able to extend them up. TMJ is a big one with a lot of people. The jaw problems, tension problems in their jaw, works very effectively on the muscles down the side of the jaw. When we're doing ribs, we'll go into the upper extremity. We have elbow problems that we treat a lot of. We see a lot of shoulder irritations. Carpal tunnel syndrome is one of the biggest things that we see now. We work on the neck and down into the elbow, down into the hand. And that one is one of the most favorite ones that patients like to see. So what happens, it works through the neck. And then what happens is there's some points in the neck area, depending which level of the spine is the most irritated. And then we go down into the elbow after this, and then down into the wrist. So different frequencies, ideally for different levels. Back into the protocols. And when we're dealing with the spine, we're dealing with low back conditions. We've got the sciatic stuff going on down into the leg. We've got different ways to loosen up the spine. And then we've got some other conditions as well. We've got the ones for the sinuses, when people have a lot of problems. We've got ones for constipation down through the stomach, helps loosen up everything through the bowels. Asthma ones are really good for breathing. So there's a lot of applications, and these are just the basic ones that when the student or the chiropractor comes in and learns, we want them to have something they can use when they get home. We also have a lot of advanced protocols that we teach at different levels, so we make sure what they have. Or if they work, let's say, specifically in a specific sports program, they're a golf program, they're a volleyball program, they're a weightlifter, we have specific protocols exactly for those doctors too, but we want them to have a basis of the normal things that they will see in day-to-day office when they initially start using the spinal line system. So